Hello, this is Eric Goplerud. I'd like to welcome you to this presentation this afternoon, or at afternoon from where I am, for the SBIRT ATTC. The presentation will be approximately an hour, and then I hope that what we will have is the opportunity to have a good discussion, at least a good discussion through the chat feature. I'm Eric Goplerud. I'm a Senior Vice President at NORC at the University of Chicago, and I'm also a co-principal investigator of the National SBIRT ATTC. This webinar is produced in partnership with NORC, NADAC, the Association for Addiction Counselors, the National Screening, Brief Intervention, and Referral to Treatment Addiction Technology Transfer Center, and the BIG initiative, BIG standing for the Brief Intervention Group Initiative. This is one of a webinar series that is done by this partnership. A number of them have already been done and have been archived and are available to be downloaded and listened to. Five have already been done and are available on the hospitalsbirt.webs.com/webinars.htm, which is down at the bottom of your screen. The webinar series also features next week a webinar on the treatment of tobacco dependence in healthcare settings, best practices. In June, applying SBIRT to depression, prescription medication abuse, tobacco use, trauma, and other concerns. In July will be a webinar on training integrated behavioral health and social work, in which we will hear for the first time the results of a number of efforts in schools of social work to integrate substance use, mental health into a primary health curriculum that is being led right now by the Council for Social Work Education and National Council for Community Health, or excuse me, National Council for Behavioral Health. And then in August, Why Integrate Care. So all of these come with free continuing education credits, and if you have any question, please contact us. All of the PowerPoint slides will be available. There is a brief continuing education quiz if you would like or need continuing education credits. We are currently recording, and all of our webinars, so that others can listen to them, are recorded, and they are at the website. This recording and the webinar will be available within a day or two up on the website there below, the hospitalsbirt.webs.com, pitchingesbirt.htm. If you would like to ask questions, and I sure hope that you do, there is a box over on usually the right-hand side of your screen, and there is a place to type in your questions. Please do so. If there are notes that are of the order of, I'm not getting sound, or I've got a lousy connection, or technical kinds of issues, please type those in, and Misty Story, who is our incredible operations webinar manager, will respond to you. If you have questions along the way of what does some acronym mean, or could you explain more about a particular issue or instance, please type that in, and I'll try to monitor that as I am talking with you. But what I really hope is that as we go through, you're going to see things that spark ideas or spark questions, type them in, and what we'll do is try to turn that as much as we can into a discussion. We have a couple of experts who have been working in this area in a very applied way of talking to payers about substance use screening, brief intervention, and treatment. And what I hope that we'll be able to do is to get some discussion from them where you can get the practical kinds of issues of clearly this is a tough sell. That's why we're talking about this pitch and pitching, but their experiences and their reactions to some of the points that I'll be making over the course of the next 45 minutes or an hour. And then either depending on how we are able to work technology, probably the way that we will work a discussion is through this chat feature over on the right. Our amazing technical facilitator is Misty Story, who is the Director of Training and Professional Development for NADAC, the Association for Addictions Professionals, and also she is our technical expert and facilitator for this webinar series of the National SBIRT ATTC. So if you have technical problems of any kind, ask her. Hopefully I have the content, but she has the technology. So now to talk about how do we pitch SBIRT, and when I say SBIRT, I'm really talking about how do we pitch and talk about substance use screening, counseling, treatment, and treatment of a whole spectrum of types of treatment to payers. And payers may be or would include insurers, Medicaid, ACOs, primary care or FQHCs, the variety of those, and consumers. How can we talk about substance use screening and treatment in a way that is compelling, that makes sense to the payers and to those people who control the purses? Well, one of the key issues or insights is that alcohol, and this slide here shows, alcohol causes or is a contributor to more than 70 diseases and injuries. Now, if you look over on the left-hand side, these statistics come from the Centers for Disease Control and Prevention. On the left-hand side are the primarily injuries, which are associated injuries, child abuse, suicide, accidental falls, that are associated with risky and hazardous use and are more common among people who are, I'll say, under 35 years of age or so. The grayish columns are the likelihood or the percentage of those conditions or those injuries which are associated with alcohol use. May or may not be caused. I mean, if you take a look down there at, say, work/machine injuries, and it says 0.07. Based on research, literature reviews, about 7% of work/machine injuries are either caused by or are alcohol is contributing to that injury. So on the left-hand column, these are the conditions for which alcohol plays a contributing or causative role, which impacts the healthcare setting, or where you're likely to see people with alcohol and drugs showing up. If you look at the right-hand column, what you see there are the conditions that are associated with long-term persistent use of alcohol. Tend to be for people who are over 35. In fact, the modal or the average age often is up in the mid-50s, 60s, even 70s when these conditions show up. So it's likely that many of these conditions you're not going to see in the younger population. And as you look at these two, you say, okay, now where is it that we might be placing substance use screening and treatment where it's going to help solve the issue for the healthcare setting if they do a better job of screening, where we're providing a benefit for the healthcare system. This slide, which is a bit old now, is the 10 leading causes of death in the United States, according to the Centers for Disease Control and Prevention. And I've colored in blue those injuries or causes of death where you have a substantial contribution or cause by alcohol or drugs. And if you notice, in the ages between 1 and 44, unintentional injury is at the very top, followed by homicide, suicide is there in the top 4 or so. And we know that homicide and suicide are often facilitated by people who are drinking or using other substances where the act is disinhibited by the alcohol or drug use. So between the ages of about 1 and 44, a very common cause of death is associated with substance use. It's not what's going to end up on the death certificate, but it is going to be one of the causative factors. Now, when we take a look at the overall prevalence of alcohol or drug use disorders in the general population of adolescents and adults, about 8 to 9% of the population would meet a full diagnostic criteria of a substance use disorder. But in most healthcare settings, fewer than 1 out of 100 adolescents and adults receives a diagnosis or receives substance use treatment services in any year. In other words, it's about 10 to 15% of the people who could benefit, who have a substance use disorder, who are getting identified and treated. So we could look at this as the healthcare system is doing a terrible job and wring our hands, or another way of looking at it is, what an incredible opportunity. Now, substance use screening and treatment, you've all seen the triangle. And this is just another way of looking at the triangle. This particular triangle came from Mark Willenbring, where what he points out, if we look to the far right-hand corner, are severe dependents, perhaps 1% or so of the adolescent and adult population meeting the criteria of severe and persistent alcohol use, withdrawal symptoms, and impairment of social and work functioning, family functioning. There are about another 3% who meet the criteria of functional dependence. They're able to work, they may still have their families, but they are drinking at such sustained levels that they are physiologically dependent and are at risk of developing the diseases that are associated with alcohol use, persistent and heavy alcohol use. And then there's another 26% or so who are at-risk drinkers who have minimal or no symptoms of alcohol use disorders. Now, at the bottom is a reference to an article by Adil Gawande. Last August in the New Yorker, Gawande, who is I think a neurosurgeon and an incredible writer about healthcare quality, wrote an article about what he called slow ideas in healthcare. And what Gawande was talking about, he took as an example, he said that that the discovery of anesthetics and the discovery of antiseptics, antisepsis, meaning hand washing or keeping a wound as clean as possible, were both discovered at about the same time. Anesthetics, chloroform or other ways of reducing or of anesthetizing patients in surgery or in injury, very, very quickly swept through the healthcare system worldwide. And physicians who had previously had to have patients held down, looked into the terror-stricken eyes, the pain-stricken eyes of their patients as they were doing surgery, no longer had to look in their eyes. Hand washing, we still are not really getting the healthcare setting to do it as frequently as it should be in order to keep wounds clean and reduce infection. Gowanda says, well, what's the difference? The difference that he points out is that anesthetics took away a problem for physicians. They took away a hassle, the hassle of having to hold the patient down, the hassle of hearing him scream, the hassle of looking at the terror in his eyes. Whereas hand washing adds a hassle. So as we think about Gowanda's slow ideas, how is it that we can talk about substance use, screening, brief intervention, and treatment in ways that are more over on the side of anesthetics, more on the side of taking away, providing as Chris Wilkins says, taking away, being the aspirin for the healthcare system's headache, rather than saying, you really need to do this because it's good for your patients. Here, add another screen. Or we really think it's important for public health that you be co-managing the comorbidities of your patients. As we think about how we can describe our services and pitch substance use screening and treatment to payers, we have to think in terms of, are we taking away a problem or are we adding effort? Because adding effort we still don't get everybody to wash their hands. So where might we find the best places to go to to provide the aspirin for the healthcare system's headache? Well, this is a very rough schematic of the prevalence or the likely prevalence in a general population of a primary or a comorbid substance use disorder in populations. And if you can see on the far right-hand side, in trauma care, patients who are traumatically injured, you are likely to have anywhere between 40 to 60% of patients coming in with traumatic injuries. They're associated with their alcohol or drug use. Similarly, inpatient psychiatry, about half of the inpatient psychiatric patients have a comorbid or a primary substance use disorder. So if you take the Willie Sutton model of robbing the bank because that's where the money is, if you're looking for where are their headaches to be solved, the first place you probably would want to look is over in trauma care and in inpatient psychiatry. Next, moving over to the left is outpatient, yeah, I think I've got that right. Yes, outpatient mental health, which is in the maroon color. And there it's a approximately 30%, 30 to 33% of community mental health, community behavioral health patients have either a primary or secondary substance use disorder. And then as you go further on to the left, emergency department, inpatient medical, and ambulatory medical to lower and lower sort of hit rates. Now, I think this is valuable, given that many of us have worked very hard to try to get primary care to attend to the substance use conditions of the patients who are coming in for primary care services. On a population-wide basis, sure makes an awful lot of sense to try to integrate substance use screening and treatment into, say, community health center practice or into primary care practices. But if you look at sort of where the hit rate is, meaning where you could be benefiting the healthcare system relative to the hassle of adding a screening or adding counseling or potentially disrupting patient flow, you get a much lower hit rate over in ambulatory medical care, but you can almost counsel or talk to almost anybody walking in or being carried into trauma care, or who is admitted into an inpatient psychiatric service, and you're going to have a person who's impacted by alcohol or drug use. So as we think about where to go and how to talk to payers and to also talk to healthcare systems, and so where they're likely to be sensitive to the argument that substance use screening and treatment is a good thing to do, it's valuable to be thinking about how is it going to be taking away a problem for them or easing a problem for them, rather than adding something that they're going to see as adding extra hassle. So I'm going to talk about where there look like some hot spots, places where there is a good likelihood that we can combine good treatment, the technology that we know and that has been well established through research, through a lot of clinical practice, where substance use services, screening and treatment can benefit a healthcare system and produce value for the healthcare setting and to payers. And one of the most promising is in hospitals. And it's now, based on the science, there is substantial reason to believe that screening and treating acutely ill and injured patients with a comorbid substance use can reduce their post-admission alcohol consumption at 6 months, at 9 months. Self-report at 1 year favors brief interventions, and significantly fewer deaths at 6 months and 1 year. There are some research studies, including several studies and reports now from Richard Sates, that suggest that screening and brief intervention for dependent substance users in some hospital settings may not be effective, and certainly it is not uniformly effective for all patients who have a comorbid substance use. But Cochrane collaboration, which uses a standardized way of doing and analyzing research literature, has shown from 14 randomized controlled trials with adults and adolescents that screening and treatment of comorbidly ill or injured patients is effective. Now, one of the best and earliest studies of screening and brief intervention in trauma care was done at Harborview Medical Center, a randomized controlled trial funded by the National Institutes for Alcohol and Alcohol Abuse, Patients were screened with the blood alcohol and with a questionnaire, and went through the research consenting and were consented for follow-up and randomized either to receiving a 15 to 30-minute intervention plus a follow-up letter or just standard services in the trauma care. And this is a slide. The research was done by Larry Gentilello, Dennis Rivera, and others. And what this slide shows is that the yellow line are the control patients. They're patients who had a substance use condition, traumatically injured, who did not receive the brief intervention, and their risk of re-injury, and there's a comparable picture of rehospitalization. The red line is patients who received the brief intervention. The likelihood of injury reoccurrence, patient crashing their car again, ending up in the hospital, was about twice as large for patients who did not receive the brief intervention. Changes in alcohol consumption. At 6 months, both the control and the intervention population reduced their alcohol use, but for those patients who did not receive the brief intervention, by 12 months after their injury, they were drinking slightly higher than at the time of injury, whereas those who received the brief intervention continued to decline in their alcohol use. As well, there have been studies that have looked at a cost-benefit study that Gentilello did that showed that there was a net cost saving to this is a cost saving to the insurer. This is a cost saving to Medicaid or cost saving to Aetna or Blue Cross Blue Shield of approximately $3.81 for every $1 that was spent on the screening and brief intervention of the traumatically injured patient. If this were done universally, this was back in 2000, Gentilello estimated that there would be a saving to the insurer, and ultimately that means back in the pocket of the consumer, of about $1.8 billion. Now, this obviously is an argument that you would make, or a pitch that would be made to health insurers, including Medicaid, or commercial insurers, showing the cost benefit of screening in the hospital. In addition, NNT means number needed to treat. Carol Shermer found that for 9 patients who receive a brief intervention in trauma care, reduced by 1 DUI arrest in the 1 year following the brief interventions. Or in other words, if on average a person drives under the influence about 2,000 times before they are stopped, pulled over, that 9 brief interventions in the ED or in the trauma unit, 9 brief interventions could reduce by as much as 2,000 or maybe more instances of driving while under the influence, which substantially increases not only the individual's risk of injury, but also my risk of injury if I'm driving on the same street as this guy or this person. Screening and brief interventions in hospital emergency departments has also been well studied. Nilsson did a systematic review of emergency department screening and brief intervention. He identified 12 randomized controlled trials with pre and post brief intervention results, and 11 out of 12 observed significant effects on alcohol intake, risky drinking practices, alcohol-related negative consequences, and frequency of injury. The picture behind this slide is of Ed Bernstein demonstrating an absolutely fabulous brief intervention he has a series of training videos out at the bni-art.org website, bni-art. It's a training site that was developed, I think, at Boston University. But anyway, it's terrific, and the systematic reviews have suggested that at least for alcohol, screening and brief intervention in the emergency department is an effective intervention. And there are consequences that matter to hospitals. I hope one of the things you're getting here is that you're getting a set of slides that then you can use in having discussions with payers. That's part of the value, hopefully, of this set. And here's one of the consequences that matters now to hospitals, which is patients who have a substance use disorder that is not identified and managed inpatient have a 2 or more times greater risk of rapid rehospitalization. Right now, because hospitals are getting penalized for having higher than average rehospitalization rates, patients who are discharged and then rehospitalized within 30 days of discharge, leading to financial penalties to hospitals from Medicare. You can see here that the rates of rapid reutilization of emergency departments and of hospitalization is about twice as great for patients with a substance use disorder who have not been identified and managed. So these kind of results have gotten some attention. The American College of Surgeons Committee on Trauma, which is the accrediting body for trauma care, mandated in their 2006 manual and subsequently that level 1 and level 2 trauma centers have to demonstrate that they can screen and provide brief counseling for risky alcohol use in order to retain their accreditation. The Joint Commission, or what used to be known as the Joint Commission for Accreditation of Healthcare Organizations, has developed a set of 4 screening, brief intervention, treatment, and follow-up performance measures for hospitalized inpatients. And starting in January 2014, all freestanding psychiatric hospitals and psych units of general hospitals are required to collect data on their rates of screening all patients coming into their psych units for risky alcohol use, and to report them starting in January 2015 to CMS. And these will be performance metrics that not only do they get incentive payments if they report these measures or get dinged, meaning they get a lower rate of reimbursement if they don't report the measures, but these measures will then be publicly reported, and we can compare, and the general public can compare between hospitals, among other things, looking at their rates of screening for risky drinking in their psych units. There are a number of examples where there are hospitals, and often hospitals with a community specialty substance use treatment program as partners, where they are working to identify and to manage the comorbid substance use of patients who are in the hospital. These are general hospital admissions as well as psych admissions, but they're primarily general hospital admissions where a patient, for example, may be alcohol dependent and at risk of withdrawal, or have prescription opioids on board and complicates or delays surgery because of the problems of anesthetics. And here are some places where we can go now and see practical examples of where screening and counseling is taking place in these hospitals. Falmouth Hospital with their partner Gosnold on Cape Cod, Denver General Hospital, Gunderson Lutheran Hospital, working with Whipple, with Rich Brown's group, the SBIRT program in Wisconsin, Oregon Health Sciences University, and Jim Winkle, Christiana Hospital, Terry Horton, Salina General Hospital, and Les Sperling in Central Kansas Foundation, Temple University, and Treatment Research Institute, often with a substance use partner. One of them, just as an example, is a collaboration between a community hospital, the Falmouth Hospital, and Gosnold on Cape Cod. The hospital is a 100-bed medical surgical hospital. Gosnold is a 50-bed addiction treatment center. They're on the same campus, but have sort of been mutual. They share a campus, but didn't share much as far as commonality. Gosnold was a place to send those patients who you didn't want in your unit. So right now, or they have been working together. What changed it? The near loss of a patient who went into withdrawal in the hospital, and the chief operating officer saw the really substantial financial risk, liability risk of not managing the comorbid substance use while in the hospital. So what were some of the effects? They took a look at patients who, the medical records of patients who, prior to their bringing a treatment program, screening and co-management inpatient for medically ill patients. They looked at a set of patients before they came, the program started, and then after. Before the program, about 50% of the patients with comorbid substance use were treated in the ICU. After the intervention and the program was put in place, only about 10% went to the ICU. The cost per day was 30 to 40% lower in the med-surg beds. But perhaps even more important is this slide. Before the collaboration, the average length of stay for patients with a comorbid substance use was almost 15 days. For those patients who received the co-management of substance use with their medical condition, the average length of stay was 6 days. Now, if you were getting paid on a per-day basis in your hospital, well, it'd be pretty terrific if you can keep a patient there an extra, whatever that is, 7 days, 8 days. But hospitals now are primarily, and even more in the future, are being paid on what's called a DRG rate, which is you get paid essentially a fixed price for example, a simple stroke. And if the hospital, this is based on an average experience in that hospital or hospitals of that type, you may get paid $6,000. If a patient stays longer than the average, the hospital has to eat that extra cost. If the patient stays less, a shorter period of time, the hospital gets to put the money in their pocket. They get paid that same $6,000. So if by doing, managing risk of withdrawal and starting treatment in the hospital of a comorbid patient can be initiated, you are saving the hospital unfunded days. You're making also available beds that can be filled with additional paying patients. So not only is this reducing the clinical issues of patients with comorbid substance use and the difficulty of management on the med-surg units, it also saves the hospital money and saves the health system money as well. So another example, another hospital that's doing a similar kind of program is Project Engage at Christiana Hospital in Delaware, which targets hospitalized, same kind of people, hospitalized substance users at withdrawal risk or with significant comorbid addiction. They use peer-to-peer interventions, peer counselors, and motivational interviewing, and then have an addictions community social worker to assist in removing barriers to transitional care and help with integrating into the hospital milieu, and then also integrating back out into substance use treatments that are in the community for patients for whom there are who have, say, no insurance or have where publicly supported services are not available. The community integration may be integration into mutual support groups, or it may be into primary care with some addiction treatment. And this is what they found with when they took a look at an unsystematic 18 patients, I think it is, 18 patients, and looked at Medicaid claims for patients before hospitalization and post-hospitalization. And what they found overall was a reasonable savings of $36,000 over 18 patients. But I think what's more important, more interesting, is what happened to the shape of the services. You got fewer medical and psychiatric emergency activities. Well, actually, if I take a look at it, behavioral substance, inpatient admits went up. You got fewer medical admits, fewer emergency department services, and you got more mental health services appropriately, and substance use services. And you also got more ambulatory care. You got more primary care office visits. And yet overall you had savings. Well, this could be just a fluke of you counted the right 18 people. So then they took a look at some more, again, unsystematic, not what the researchers would say is a good randomized controlled trial, just looking at the medical records, the charges. And you find for the next two sets of cohorts, the same pattern shows, which is that medical inpatient admits go down, ED visits go down, and you get savings. This is the kind of results that Terry Horton in Delaware told me. Their Medicaid agency said, well, this saving us money, and they gave them a grant to fund 2 additional addictions counselors in the inpatient setting. Another program, it's either Selena or Salina, and hopefully Les Sperling can tell me which it is. Regional Health Center, a 199-bed acute care regional hospital, 27,000 ED presentations per year. Alcohol and drugs disorders was the second most frequent readmission. So patients who had a discharge diagnosis that was a substance use diagnosis, they were the second most likely, based on rates of discharge, of coming back again within 30 days. The substance use treatment program provided 24/7 coverage of substance use in their emergency department. Full-time substance use staff on the medical and surgical floors provided warm handoffs to all substance use mental health services and screened all patients, put into the routine, the medical record, screened all patients for substance use and provided brief intervention in 2013. The outcomes, readmission rates for DRGs dropped from 2nd to 13th. 70% of alcohol and drug withdrawal lengths of stay were 3 days or less. 83% of substance use disorder patients were triaged in the emergency department who were triaged were not admitted to the inpatient unit. 58% of the patients recommended for further intervention attended the first 2 appointments. And we know how infrequent it is that when a patient is, a recommendation from the ED is to go to, or a hospital is to go to the next level of care, on average that's about 15%. By having, as part of the medical team, a substance use specialist, those rates were more than triple what is the expected or the usual rates. Adverse staff and patient incidents decreased, and their program's detox admissions increased substantially, leading to an increase in commercial insurance reimbursement. Now the next hot spot, prenatal screening and case management. I'm going to particularly talk about a program developed at Kaiser Permanente, Northern California, called the Early Start Program. And we have had in this webinar series, and I encourage you all to take a look into past webinars, we had a tremendous presentation by Nancy Goler, who is an OBGYN doc who developed this project and who has published on it in the major OBGYN journal. And frankly, also I should mention that past webinars in this series have been done by Terry Horton and Project Engage, Les Sperling, and the program out in Kansas, and Ray Tomasi and the program in Cape Cod and Falmouth. So if you're interested in really getting into and finding more detail, I encourage you to go to the webinars that we've had in this series, and you'll just find tremendous information, insight that would, I think, further bolster the case for why these types of interventions will be that aspirin for the healthcare system's headaches. So what in Kaiser Permanente they have done is in their prenatal programs, the first time that a patient, that a woman comes in for prenatal care, often it's for a sonogram, there's a screening questionnaire which includes asking, as part of the health assessment, asking questions about alcohol and tobacco use, I think also questions about potential domestic violence, and also with patient consent, urine tox. They placed a licensed mental health provider, a social worker, in the department of OBGYN, and they linked their appointments for patients who were screened positive for alcohol use. They linked those appointments to the routine prenatal care appointments, so that there was no distinction made between the care and the checkup that you were getting for fetal development and the counseling that you received concerning alcohol, drug, tobacco use. The aim for the Early Start program was abstinence through the whole period of pregnancy. All women were educated about substance use and alcohol risk. And these are results. I believe the screening rate, or the number of patients who were covered by this, was something like 44,000 patients. So this is not it was not a randomized controlled trial or anything like that, but it covers lots and lots of patients. SAF means screening and follow-up. SA is screening and assessment. S is screening only, but the patient did not return for assessment, full workup, but they screened positive. And then control is women who screened and screened negative, who did not have alcohol drug use. And on this one, it shows the rates of preterm delivery, less than 37 weeks. And you can see that women who screened and were assessed were at higher but not significantly higher rates of preterm delivery than controls. But screened only were significantly higher. Almost 1 out of 5 pregnant women who were using substances, who screened and did not receive the brief counseling, had preterm deliveries. The rates of NICU use, neonatal assisted ventilation, similar pattern, 2.2 times higher than the screening and follow-up, and 3.1 times higher than the controls. Stillborns, or intrauterine fetal demise, were 14 times more likely in the screen positive than in the screening and follow-up or control groups. 7% of pregnant women who screened positive and did not receive the assessment and follow-up had stillborns. The results is that the total cost of the patients who were screened but did not receive the assessment or follow-up, and this was not that they denied the service, it was that the patients did not come back for the service or said that they did not want the service. The overall costs, as you can see, were about $7,000 more overall who screened positive but received no follow-up for their substance use services. The overall estimate is, if this was done routinely, that we would be saving several $billion a year, and we would be saving several thousand stillborns. So, Kaiser is an unusual place. It's both an insurance company and a service and a healthcare organization, and so it is in the interests of Kaiser, but it would also be in the interests of Aetna or Cigna or Humana or Blue Cross Blue Shield or whatever it is, in Anthem, WellPoint, to institute screening in a place and the brief counseling in a place where the risks and the consequences of substance use and continued substance use, especially alcohol use, alcohol and tobacco, lead to very high costs in especially the neonatal intensive care unit costs. Third hotspot, youth and young adult high-risk users. A summary of almost 17,000 adolescents who were served in 148 local CSAT programs, followed quarterly for 6 and 12 months. They found that overall, adolescents averaged about $4,000 in costs to taxpayers in the 90 days before intake, before they received treatment. In the 12 months after, the cost, $15,000 a year, the cost was $4,500. In other words, the screening and counseling of adolescents led to a 3 times or a 300% reduction in costs to the insurer. Now, where do we find a lot of teen and young adults? The primary location is school health, and school-based and school-linked health programs, where substance use screening is being innovated by the Treatment Research Institute, and where the Conrad Hilton Foundation is really leading the way right now to an intensive focus on adolescent substance use screening, brief intervention, and treatment. There are a number of programs, including a demonstration by Treatment Research Institute of, I believe it is 5 school-based health programs testing and replicating a program that was developed by TRI. Fourth hotspot, or a little bit hotspot. It's a tough hotspot, which is the ambulatory primary care SBIRT, where an awful lot of us have spent a lot of time. And I would encourage you, if you're interested, is to take a look at the Brief Intervention Group website. Take a look at or Google the BIG initiative or the Brief Intervention Group. There's a lot of research and data there. It's very clear from randomized controlled trials that there is savings and a modest effect of screening patients in primary care and providing brief counseling in primary care. And here are a number of those examples. But we have also had some instances where the brief intervention either doesn't produce greater effect than just providing feedback, or even the screening itself and asking patients about their drinking in a clinical setting, in the doctor's office, that in itself seems to have an effect which is as strong or almost as strong as the brief interventions. These are results from just an initial poll of 250 patients whose doctors had submitted claims to a large insurance company for brief intervention. The AMA approved procedure codes for alcohol and drug screening and brief intervention, either the 15 to 30-minute codes or the 30-plus minute codes for screening and brief intervention. So these are 247 almost random physician claims, and this large insurance company took a look at 12 months prior and what they paid for that patient 12 months before, in the 12 months before the brief intervention claim came in, and the 12 months after. There's sort of two things to look at here. The one that the insurance company looked at was the bottom one, which said that when you compared the 12 months after to the 12 months before the screening and brief intervention, there was a 15% reduction in medical costs. They had to put 15% less of their or your money into paying claims in the 12 months after the brief intervention. But what I'm really interested in, and what I think is very, very important, is the shape of the services. Much like what we saw earlier with the hospitals, you see that behavioral health inpatient days decreased, medical inpatient days decreased, emergency department visits decreased. But the kinds of services that you would hope would take place because you're starting counseling, you've identified the substance use issue, partial hospital and IOP visits increased, psychiatric visits increased, therapist visits increased. You've got, and I don't have the number in here, but pharmaceutical costs increased. Yet what you find is overall, you're moving patients out of crisis and acute care and into what you hope is the appropriate level of care, which is primary care and management of the behavioral condition. The last hotspot is the treatment of substance use disorders with medications. And notice I'm not calling it medication-assisted treatment. It is treatment with medications. We don't call the treatment of diabetes medication-assisted diabetes treatment. We call it medical treatment, of which counseling, clinical supports, preventive care are all part of good medical care, which generally also involves medications. A couple of a little bit busy slides. One of the things this is probably going to demonstrate to you is that hopefully I have better content than I have PowerPoint capabilities, is that this is an analysis of pharmaceutical claims and health insurance claims, looking at, this is for opioid dependence, admissions for patients with opioid dependence, admissions in the 6 months after the date at which they started treatment. And this is either depot naltrexone, oral naltrexone, buprenorphine, methadone, or drug-free. And drug-free simply means it is treatment where the patient is in a treatment program or referred to a treatment program that does not use medications. And what I think is obvious here is you can see that admissions when patients were referred to a drug-free program were substantially higher for detox, for inpatient opiate treatment, and for inpatient other services. Inpatient costs, not surprisingly, were also significantly higher, and they also were higher for patients with methadone. And that may be an artifact. This is looking at just claims. This is not some kind of a controlled study. And it is possible, in fact, it is likely that the methadone patients, where you see inpatient other being substantially higher there, maybe because methadone patients are on average older than the patients who have who are receiving the other medications or in the drug-free condition. The overall total costs, when you include the costs of medications, you include outpatient costs, psychiatric costs, inpatient, it is clear that you get, from a payer perspective, the costs for methadone and drug-free are substantially higher and significantly higher than with the other medications. In Massachusetts, comparing the experience in Medicaid with treatment alternatives of buprenorphine, methadone, drug-free, again, meaning a program that does not use medications, or no treatment at all. Medicaid expenditures per person per month in the 6 months post-index date, meaning the date at which they were referred to treatment. This does not mean that the patient was on any of these medications through the whole period of time. It was that they received one script, or they received, this was the referral to which they were sent or referred. And what you can see is that patients who received no treatment were substantially more expensive. Their odds of relapse were nearly 3 times higher than for buprenorphine, 4 times higher than for methadone, and their odds of dying within the 6 months following their index admission, if they received no treatment, was 2.25 times higher. But I think the important point here is that receiving no treatment is more expensive than receiving treatment when you include the costs of the medications and all the other costs. Same kinds of patterns we see with alcohol dependence. Again, comparison of depot or long-acting naltrexone, oral naltrexone, disulfiram or antabuse, acamprosate, and drug-free, meaning not using medications. The post-6 month inpatient utilization per 1,000 alcohol-dependent patients, you can see is substantially higher for rehab, detox rehab, and alcohol-related inpatient services in programs where medications are not used. This is the cost for inpatient, and not surprisingly, we see that the costs are substantially higher for drug-free. Acamprosate, it's not clear exactly what's going on there, but one of the questions sometimes raised is this is only the medications are prescribed and we know that adherence to acamprosate medication regimens is not very good. The overall costs, including the costs of medications, the costs of medical services, inpatient services, for the 6 months per patient in the 6 months following, you can see that there are significant differences with acamprosate and drug-free as being substantially more expensive. So investing in substance use treatment produces a positive return on investment. Substance use treatment has an ROI, depending on what study you look at, of between $1.28 to $7 for every dollar invested. I tend to believe more it's around the middle, which is what we see for other care management programs. But consequently, we can see that there are savings to taxpayers or to payers of between $1.25 to $7. Now, how does this happen? Well, patients themselves don't disappear, as our no treatment example back here shows. Let's see if I can find it. Here we go. Yeah. What it shows here, patient who does not get care is going to be more expensive. They're more likely to relapse, and they're more likely to die. Okay, so how are we going to get to this? Well, it's important that what we do is move to a system, and we focus on where is it that by providing our substance use screening and treatment, we can be solving problems for the healthcare setting and for the healthcare payers, where it's in their interest, just as it was to do anesthetics. It's going to help solve their problems, not us saying, here's an extra thing to do. We know from our SBIRT programs, it's a really hard sell to say, here's something else we'd like you to do in a really crazy busy schedule. And I hope that these examples will give you some ideas of where it is that we can go, and you can go, to talk to payers, to talk to service delivery systems, where you can say, by doing some focal screening and treatment, we can help solve some of your problems. Patient care will be better. Overall population health will be better, and you'll save money. Now, if we can get the technology to work, and I'm not sure that we can do it, I would like to see if we can get comments or observations from 3 people who have said that they would try to be on the call, who have actually been doing this work, whereas what I'm a little more of a researcher and I'm telling you about their work, they can tell you more directly about what it is they've been doing and about how they talk and have talked to insurers and payers. So, Misty, if you can organize this, I understand Jim Winkle from Oregon is on the line. Jim?
Yeah, can you hear me?
Yep.
Great. Well, thanks for this presentation, Eric. Showing all this evidence, in my experience, does really help make a convincing argument when you're talking with payers. I don't know what really more I need to add other than in Oregon it's kind of unique because clinics with Medicaid patients are now required, or at least heavily incentivized, to do SBIRT because of our payment structure with Medicaid. So our coordinated care organizations, 2% of their Medicaid payments are withheld unless they can show that the clinics they contract with are performing SBIRT. So we don't really have to make such a strong argument to the payers necessarily in Oregon, but the same argument to give during the webinar is the same ones why Oregon Medicaid chose to choose SBIRT as an incentive measure.
Well, one of the things that is that I probably didn't talk about enough is that there's nothing like a mandate to increase the uptake. And in Oregon now, you do have a mandate that community health centers and ACOs and health homes have to do routine screening.
Yeah, pretty much the baseline before it became a mandate was, like other states, pretty much zero, at least according to billing codes and also anecdotally. But once it became this incentivized mandate, every clinic practically wants to know what is SBIRT, how do we implement it. One drawback, though, is when the state is using billing codes to track SBIRT, and as folks probably know, that's problematic for a number of reasons. And hopefully in a couple of years we'll move to more of an EMR-based reporting system. But my feeling now is like SBIRT is now taken off much more often, implemented at a higher rate than what the billing codes portray so far.
Terrific. I understand that in California there's a similar mandate, and in Missouri that is now built into the medical homes for the Medicaid demonstration, and the rates are just looking terrific when you get the combination of the mandate and somebody is paying for it.
Yeah, and maybe the third factor is just securing buy-in from clinic leadership. A lot of times when clinics accept an SBIRT training, it's usually the social workers, the office managers, nurses, and some clinicians like PAs who come. But unless the providers are really bought into this, they know the evidence base behind SBIRT, the implementation can falter. But I've noticed that if you give a brief, kind of like this webinar presentation to clinic leadership, they understand the evidence base behind it. Implementation is much more likely to be sustainable.
Great. Well, thank you. And if anyone wants to see an absolutely terrific website, you should go to the OregonSBIRT.org. Is that right?
SBIRTOregon.org. Yeah.
SBIRTOregon.org. There is an absolutely terrific portion on it on reimbursement, and shows a real how-to of turning SBIRT into a very straightforward script for healthcare providers to follow. And by simply clicking on the script, you also populate a billing, all the information necessary for billing, and it goes into the EHR, which is very smart. Let me see if I can answer some of the questions here. And let's see if we can answer it. Someone was asking about what is the source of the data, and what we can do is put the citations also along with the webinar slides. It says, if for whatever reason a patient is not able to receive a brief intervention, but a clinician hands them some related brochures at discharge, is this documented as a brief intervention? The answer to that is sort of, it depends, and it's sort of for whom are you asking? There's reasonably decent information showing that a screening and then provision of written feedback, and it can be just as standardized feedback as giving someone the book, the little booklet, Rethinking Drinking by NIAAA, has a significant, a modest but significant effect on people's drinking and risk of alcohol-related health and other consequences. If what you're asking about if a patient doesn't receive the brief intervention but is handed some brochures at discharge, is that a billable event? In that case, it probably has more to do with how much time is spent doing the screening and handing the materials. But the important part here is the feedback, and depending on the condition, it's unlikely, if a patient is dependent, that merely handing them a brochure is going to be enough. For a lifelong pattern or genetic predisposition to dependence, it's unlikely that it would be sufficient for just someone to change their life through brief counseling. It does happen. It does happen, especially the research is pretty good around traumatic care or traumatically injured. But handing somebody a brochure will have a modest effect, and it appears to be almost as strong, and in some studies as strong as the brief counseling. There's a question around how are the models of brief intervention, or that I'm showing here, how are they staffed, how are they funded, and are any prevention program staff involved, or is it just treatment staff? The staffing really has been, there is very little evidence that there is a one or another profession which is better at or more effective at delivering the counseling or treatment. The model that is used in Christiana Hospital and in a number of these hospital settings are using trained peer counselors. Others use certified addictions counselors, and still others use nurses or social workers. It appears that there is not a whole lot of difference between in the effectiveness. Now, having said that, some research looking at the that does look at how do patients receive and perceive advice being given about drinking from different professionals, that nurses in medical settings seem to be more acceptable in asking questions, and adolescents and young adults seem to be more willing and able to talk to a nurse than to a physician about drinking and drug use. But patients also say that they prefer getting advice about cutting down from a physician, probably more a status thing. However, physicians do tend to, it's not that they're more effective, but again, patient's preference. How are these positions funded? There are many models, and probably the model that is most used and is probably the most problematic is grant-funded startup positions, which is what is often done with the SBIRT programs. An innovative program in Ohio, the Ohio SBIRT program that is now being run by Steve O'Neill, is trying something very different, and I'm very intrigued by the model. Rather than placing substance use counselors or screeners and treaters in community health centers, what the SBIRT program is doing is providing training to the health centers in how to do screening and treatment, but is acting essentially as an insurance company and saying, we will pay you for screening and brief intervention, and it is up to the health center or the primary care site to structure itself to bill the SBIRT insurance company for those services. What this does is build the capacity and integrate the substance use, or what Steve hopes, integrate the service into the practice of the health centers providing them with the services. This is also with reimbursement. This is also a model which has been done by in Baltimore in 14 community health center sites, where there's organization development consulting and how do you configure workflow and get electronic health records to support screening and counseling, but there isn't additional funding that goes to the health centers. Instead, it is, we'll show you how to organize yourself so that you can deliver that service. Another question is, let's see, how do these statistics translate to primary care FQHCs? Can you provide information strategies to pitch primary care SBIRT to commercial insurers? I think one of the slide that I showed you of the impact of screening and brief intervention in primary care goes part way towards that, is that it shows how the savings are for commercial insurance. There is a report now published that Rich Brown has done of the cost benefit to commercial sector to insurance that is out in the research literature. So it's one of the first cost effectiveness or cost benefit studies which show what the savings are to insurers if they do and support screening and brief intervention. But if you want to follow up with me, send me an email and I'll be happy to provide more information. Let's see. I'm trying to. Are there examples of successful SBIRT projects in outpatient mental health settings, as that was an area that was mentioned in a chart early on in the presentation? Actually, off the top of my head, I don't know. So perhaps what we could do is, if any of you who are on the phone know of successful examples of screening and brief intervention management in mental health programs, if you could either type them in under the question box or in the chat box, because off the top of my head, I'm drawing a blank. Another person asked, we are working to implement SBIRT now in our ambulatory primary care settings to universally screen all patients with a goal of better screening and brief intervention, but also stigma related to substance use. Do you feel still the case is strong for this, as it looks like there may be other locations that would be of increased benefit? And I think the answer, to some extent, it depends on the environment that you're working in. As Jim Winkler mentioned, and as is the case now in California or in Missouri, where you have regulation or payment that is set up that supports ambulatory screening and brief intervention, there is a reasonable chance. Now, there is a model which is developing of the integrated behavioral health clinician, which I think is probably a more sustainable model than our usual SBIRT model. The integrated behavioral health clinician is essentially a primary care behavioral health specialist. So just like primary care docs or nurses will handle essentially anything that walks in the door, similarly, the integrated behavioral health clinician is trained to work in the pace, work in the locations of primary care practice and will handle patients on a walk-in basis, a quick referral into an examining room, a hallway consult, and we'll be doing substance use screening and depression screening and counseling for obesity and doing a diabetes class and managing childhood eating problems as they come into the primary care practice. Cherokee Health Center is a good example of one of these integrated programs. The military has now moved to this integrated behavioral health clinician model across the military health clinics. I think that may fit better. There's some very interesting research that's been done on depression and integrated depression programs. And it's been found once the grant funding goes away, a lot of the programs that are like our SBIRT programs, they have a specialized depression screener, they've got a case manager who mainly does depression. After the grant funding goes away, most of those programs go away, or they get watered down substantially. I think ambulatory care SBIRT is a difficult model to sustain because in primary care, they tend not to have something that's a specialty service, a specialty screener, which is what they would consider substance use. In places like trauma care, in places like emergency departments, and in prenatal programs, and in programs where you have a high density of people with a substance use disorder which may complicate their care, or where you can tie their care directly back to a medical, the reason that they're coming in. We're helping to solve their problems rather than us asserting, we know this is good for you. I'm a little concerned. I think we're moving very close to the end of the time for this this call. I wasn't able to get to all of the questions, and so I'm sure there's got to be a way, and I will work with Misty on going through the rest of the questions that have been raised, and we'll post answers to those questions. We'll put the questions and post the answers up on the website so that you can get your questions answered. Also, if you would like, you can send me an email, and I will get back to you with any specific questions. Now, let me see if I've got control of my, no, I don't have control anymore. Actually, Misty, my email is my last name, so GOPLERUD -Eric, ERIC, at NORC.org. Now, Misty, can you move this? Okay, there we go. People were asking about some citations to the various slides. Here are the citations, and they will be up on the hospital sbirt.webs.com site. And I want to thank you very much for listening. And I hope that this has given you some tools and some information. And please, when you get the GIPRA questions, please fill them out. Please let others know that this resource is here, and we look forward to working with you again. Again, we have the webinar series is coming up. The next webinar will be next week on the treatment of tobacco dependence in healthcare settings, followed by other uses of SBIRT. Thank you very much for attending. There will be an immediate pop-up questionnaire. Please fill it out, and also there will be a follow-up. And it basically, this is what is important for us in order to help our webinar series become more effective, and also because this is supported by the SAMHSA. The SBIRT or the GIPRA, or the follow-up questionnaires, are essential for keeping us supported so that we can keep delivering these services. So thank you very much.